Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Mirum Pharmaceuticals.
This program is presented by Medscape Education Global.
Hello, I'm Benita Kamath. I'm the Interim Division Head of Gastroenterology, Hepatology and Nutrition at the Hospital for Sick Children in Toronto, Canada. Welcome to this program titled How I Treat Alagille Syndrome. Joining me today is Richard Thompson, who is Professor of Molecular Hepatology at King's College London Hospital and the Institute of Liver Studies at King's College in London in the United Kingdom. Welcome.
Hi, Benita.
So in this program, we're going to discuss how to use IBAT inhibitors, ileal bile acid transporter inhibitors, based on patient characteristics, and try to give a practical overview of how we can incorporate these into our practice. Included in this, we will think about best strategies for monitoring patients on IBAT inhibitors. So, as we all know well, Alagille syndrome is an autosomal dominant condition characterized by high GGT cholestasis and other extrahepatic manifestations, such as cardiac disease and vascular anomalies, amongst others. We know that the liver disease is a predominant clinical feature, and it's marked with severe pruritus, fat-soluble malabsorption, xanthomas, and other features which in some patients who do not get transplanted early in life due to complications of cholestasis end up with portal hypertension and a second wave of liver transplantation in the middle age of childhood. So there's a clear need for disease-modifying therapies that can help manage the pruritus, improve quality of life, and then actually delay or perhaps even obviate the need for liver transplantation. So what is our current therapeutic landscape available for Alagille syndrome? As I always tell my trainees, we have a whole host of medications that we use to treat cholestatic pruritus, and when you have a long list, it usually means that none of them work particularly well. We typically start these patients on ursodeoxycholic acid. We sometimes offer antihistamines, which have transient effects, if any. We will then move to rifampicin. In some patients, traditionally, we used to offer cholestyramine as a bile salt binding resin, but that was typically unpalatable and difficult to administer. And our patients are often on a combination of all of these therapies in an attempt to manage the pruritus. Again, these therapies are directed against pruritus control rather than having a particular impact on disease biology. So, and of course, nutrition, as we know, is always an important part of the management of any cholestatic patient as well. That has sometimes led us to consider surgical biliary diversion in some of our patients with Alagille syndrome. There are multiple surgical approaches to this, but the idea is essentially to surgically divert bile from returning to the liver and interrupting enterohepatic circulation of bile acids. I would say that surgical biliary diversion has mixed success in patients with Alagille syndrome, most likely because it's a cholangiopathy, and so that there may be differential amounts of bile reaching the intestine in patients in Alagille syndrome. So all of this really sets the stage of a relatively inadequate group of medical therapies, a plus-minus success rate with surgical biliary diversion, to a clear gap in the therapeutic landscape for treating cholestatic pruritus and cholestasis in patients with Alagille syndrome. So Richard, what do you think about new therapies, and what's the rationale for considering IBAT inhibitors in patients with Alagille syndrome?
So, Benita, that's a fantastic introduction, and I think you ended up at exactly the right point with the consideration of surgical interruption, which we really haven't explored extensively in Alagille syndrome, much more in PFIC. But the concept of using surgical interruption was always we thought, and I think the data substantiate it now, to reduce the bile salt pool size by interrupting the return of bile salts to the liver. and hopefully by doing that reduce the concentration of bile salts in the liver itself, and therefore slow down the progression of liver disease and reduce the symptoms of pruritus. As I say, in Alagille syndrome, the data are really quite limited, but it has been used. But partly, I think, because we've felt disinclined to recommend surgical intervention where we haven't got strong evidence of its efficacy. But obviously, if we can do the same thing pharmacologically, and that's the essence of what we think we're doing with these ASBT or IBAT inhibitors, is by blocking the reabsorption of bile acids in the terminal ileum, we're interrupting the reabsorption of bile acids, we're depleting the bile salt pool size, we're reducing the requirement for the liver to transport bile acids, and then hopefully reducing the retention of bile acids in the liver, reducing the pruritus, and if it succeeds, potentially stopping the progression of disease as well. So I've recently gone into this in more detail in another Medscape program, discussing the mechanisms of action and some more of the biology, at least what we understand of it so far. So I think because the pruritus is such a major feature of Alagille syndrome, in fact, some of the very first studies using these IBAT inhibitors were in Alagille syndrome. And there's a collection of different studies of different trial designs have used both maralixibat and odevixibat and shown clear positive responses in Alagille syndrome. And the responses have primarily been looking at pruritus as an outcome, and to a lesser extent, a reduction of serum bile acids as a serum bile acids, of course, being a slightly secondary marker, we think, of what's happening inside the liver. So those clinical trials have been conducted, and it has allowed both maralixibat to be licensed in Europe and in the US. Odevixibat is currently licensed in the US, I believe, for Alagille syndrome, but so far not in Europe. So the problem we have, though, is that we have clinical trial data so far, fairly extensive clinical trial data showing efficacy and the major side effects, etc. But they are in patients who met quite rigorous inclusion criteria and exclusion criteria, and they were used in a very specific fashion alongside other pre-prescribed medications so that we could just distinguish the benefits of these drugs in those trial patients. And the trials were relatively short term, usually up to 6 months was the longest in the randomized studies. We have got open label extension data from that, and we're now slowly generating data outside clinical trials. But and I think it's the real issue we're here to discuss today is what are we learning about how we use those, because the clinical trials were a sort of slightly artificial environment and they're not quite the same as real practice. And I think we have to admit at the beginning we don't know all the answers, and we do need further studies to longitudinal data collection that really inform what we should be doing with these drugs and the role they play. But I think we can already start to make some fairly logical decisions about how they fit into our overall management of Alagille syndrome in particular. So I think probably the most informative thing to do next will be to, I think, if you could run through an example of how you've used it, Benita, in Alagille syndrome, and then we can, based on that, we can extrapolate from that into other questions that we think are really important to address.
Absolutely, Richard. I think that's exactly right. Let's get into the nitty-gritty of how we might actually do this in real practice. So this is a real case that we had at our center. This was a 6-week-old baby who was referred from another hospital for a liver transplant evaluation for worsening jaundice post-Kasai. And so the patient was referred as a patient with biliary atresia. And as I think is the right thing to do whenever you get a second opinion, one should always just go back and reevaluate the original diagnosis. We did a phenotypic evaluation of the baby and found that the child had butterfly vertebra and had pulmonary artery hypoplasia. And so we followed up with genetic testing, and I did identify a JAG1 mutation, so the diagnosis of Alagille syndrome was confirmed. So now we're dealing with a cholestatic baby who's got Alagille syndrome and has had a Kasai. So what happened with this baby? So this baby remained jaundiced, and the bilirubin rose. And we have data from the GALA database that showed that between the age of 6 and 12 months, if the bilirubin is between 5 to 10 milligrams per deciliter, that leads to an almost five-fold increased risk in liver transplantation. So those are cohort data, which is it's a statistical evaluation. I would never say that you can take a single lab value and apply that to an individual patient, but it gives you a sense that this patient is in that group of patients with the more severe phenotype of cholestasis.
And most importantly, you can give the parents a realistic example of what the likely outcomes are going to be, even at that early stage, isn't it?
Absolutely. And so you have a sense that this is a patient that's heading for transplant eventually. And we start seeing the typical problems: poor weight gain, requiring concentration of formula. And the patient did not have significant xanthomas, but what we did see was real problems with pruritus. We used our typical approach: ursodeoxycholic acid, hydroxyzine, and rifampicin. We saw very modest improvement, but the patient was persistently pruritus. And based on access, where I practice in Canada, I was able to put the patient on maralixibat as part of an expanded access program at that time. So I did not have access for odevixibat, but I think that could also have been a reasonable option based on data that we have. And so that's what we did. And the fact is, the patient did very well from a pruritus standpoint. Now, in the past, a patient who had that laboratory evidence of cholestasis, some growth impairment, and intense pruritus probably would have headed to transplant fairly quickly. But the maralixibat, the IBAT inhibitor, did make a significant difference because it managed the pruritus, improved quality of life, and allowed us to plow forward. And so the patient did require a concentrated formula, but was able to take it all by mouth, was gaining weight, had an excellent response to the IBAT inhibitor, and didn't develop any xanthomas. And so we didn't have to list the child at that early age. The patient's quality of life was good. I saw them very frequently in clinic. Subsequently, now it's about a year later, the patient has ended up being listed for transplant because the growth failure became more severe. They needed an NG tube, and then the patient started to become pruritic. But I would say this is an interesting example of where an IBAT inhibitor certainly delayed the need for transplant by at least a year, enabling the child to be bigger, less frail, and had actually greater availability of an organ when the child is bigger as well. So I think we really achieved some benefit in this case. What do you think, Richard?
So, how much of improvement did you observe? Because obviously, we've retrospectively, between us, we've gone back and done this retrospective analysis to see the improvement. And there was three things that really, after they had a year of treatment, whether their bilirubin was below 6.5, whether their bile acids below 200, or whether they improved their itch by 1 point on the itch rose scale. How many of those did she actually meet? Because obviously on those data, if she met all three of them, we said that there was 97% chance that she wouldn't need a transplant after 6 years. But at the other end, if you don't meet any of those, as you know, then there's a 66% chance that you will need a transplant.
Yes, 2 out of the 3. Pruritus response was superb, and the bile acids, they improved, but as we know in Alagille syndrome, they didn't come right down. So they did go below the threshold that you mentioned, but they were still high.
So that leads us to the question of, would there be circumstances where you wouldn't have gone down that route? Are there really patients where you think that you just shouldn't be going down the route of IBAT inhibitors and you should have carried on the original trajectory to transplantation?
Right. Now, we know in the clinical trials that patients with clearly decompensated liver disease were excluded. So we don't really know how those patients will respond or perhaps have any adverse effects in the setting of an IBAT inhibitor. So I think all we can say at this point is that one might exercise caution. I would also say, though, that if a patient is listed for transplant and has a terrible quality of life for pruritus, I might offer an IBAT inhibitor because we know they're being closely monitored. We know that in some countries you can be listed and wait a year. So I would think that in the right setting, in a tertiary referral center with appropriate close monitoring, I think I would offer an IBAT inhibitor. And at that point, your goal is just improving quality of life while you're waiting.
I think that's really important, and I don't think that we should be looking at necessarily as an alternative exactly. And we can obviously we need to get people to transplant to the best possible condition we can. And if we accepted the inevitable of transplantation, doesn't mean to say we give up on all treatment options. And obviously, the patients who were deeply jaundiced, who had very high transaminases, and that were excluded from the clinical trials. And there may be definitely patients we're now seeing who wouldn't have met the clinical trial criteria. And again, I think we can contemplate treating those patients, but with very caution, because we just don't have the safety data, etc., to show that is, not without risk. But we've got no reason to think it's dangerous. But obviously, the more severe the liver disease, the less information we have. So, when you've started a patient, obviously you've got a patient here who's got some response, but most importantly, we want to monitor the patient and again give the parents a realistic idea of which direction the patient's heading in the terms of their liver disease, at least. So, what are the things that you monitor or look for in clinic, really, that help you inform yourself and the family?
About response?
Yes, exactly.
Yes. I mean, I think the pruritus response is key. As we know, I don't think still that we have a good tool that we can use in clinical practice to assess objectively pruritus. We all use the clinician scratch scale that was developed years ago by Peter Whittington, but not in a typical fashion in which you should develop a tool. But it is a physician observed scale, so we can use that as physical manifestations. And then, of course, I typically ask questions about sleep, which I think that is probably a key issue. So I take an overall pruritus response. In the clinical trials, of course, there were patient-reported outcome tools that where scores were averaged over 2 weeks. That's just not practical for us to do in the clinic. So I think, in my practice, I rely on physical examination and sleep is really one of the big things for me. I think that's one of the things. And then monitoring transaminases and serum bile acids.
We're making diagnosis of Alagille syndrome earlier and earlier, and they haven't all got the full clinical spectrum of the whole phenotype when we make a diagnosis. And there's certainly patients that have got cholestasis, manifest maybe by jaundice, but certainly by raised serum bile acids, but they're not actually very pruritic. I mean, do we have a clear answer? Should we be treating those patients? Is it going to help?
Well, there's a practical answer, which is based around access, healthcare resource utilization, and certainly at the current time, the IBAT inhibitors in Alagille syndrome have been approved for cholestatic pruritus. So that would just be a practical answer saying, well, the patient should be pruritic. However, I think we are all thinking that really we could be altering disease biology by reducing bile acids within the body. So I would like to believe that at some point the paradigm may shift to thinking about this as a disease-modifying therapy.
I mean, it makes sense, but it certainly hasn't proven, that's for sure. And as you say, it will, for the short term at least, will be limited by what the licensed indication is.
So we've commented on symptom control, and we're sort of hinting now at this issue of altering disease biology. And of course, the goal there is, can we change the hard outcomes? Not to minimize the importance of pruritus and quality of life. We know that those are incredibly important. But what about the hard clinical outcomes for us? Hepatic decompensation, liver transplantation, death. Is this class of therapies going to alter that?
So, I mean, before the Gala study, we really thought that pruritus was the overwhelming driver towards liver transplantation. But actually, we realized that quite a number of the patients have got progressive liver disease as well. So it wasn't quite how we probably thought about it. So obviously that raises the question that treating pruritus isn't going to be the whole problem, and we are going to be faced with the issue of whether we really treated the underlying liver disease, because in the short term, it's probably the case that removing pruritus or improving pruritus significantly is going to reduce the short-term requirement for transplantation. And that's what we've seen in the large retrospective analysis that you've led, which is looking at the Gala data, which is retrospective cohort data without the use of Marilex versus the patients that have been treated with an IBAT, and looking at event-free survival. And it shows a clear distinction on that analysis. I mean, we know that analysis isn't perfect. There's a completely different between prospective data collection and the retrospective cohort collection. And I've said this many times, but I do think that everyone behaves slightly differently in clinical trials. And I know that we've tried to correct for that. And they're still left with a major difference in event-free survival between the two groups. So I don't think there's any argument that in the first few years, at least, there's a reduced requirement for liver transplantation on the IBATs. But I still believe that the majority of that is driven by pruritus. And as I say, in the Gala study, in the long-term follow-up, which we don't have for the IBATs yet, in the long-term study, it did show that there's a significant number of patients who are getting to end-stage liver disease when there's an indication for transplantation. I really think that we should be cautious and say that we are improving the pruritus. We've got clear evidence that we are delaying the need for transplantation, but I don't think we can really say exactly what proportion of patients are going to avoid transplantation by the long-term exposure to IBAT inhibitors. So, I think everyone, the physicians and the family, need to know that we are hopeful that a proportion will avoid transplantation in the long term, a greater proportion than was the case before these drugs were available, but it is still a very open question.
I totally agree, Richard. I think we're shifting the needle, but transplantation, based on our first analysis of just the Gala cohort, we know that patients who present with neonatal cholestasis, approximately 50% will need a transplant. What we don't really know yet is how significantly we can change that number overall, or as you said, we're just going to delay it rather than obviating the need completely.
Some will be delayed and some we will avoid it. I think delaying it or improving it are still major achievements, but we have to be honest to the families about what we can expect.
Absolutely. So, we've largely here been talking about the IBAT inhibitors as a class of drugs, which, we have limited data. So that's why we're making extrapolations about the class of drugs, the mechanism of action. This may be a little tricky question, but I think it's valuable for us to ask you as a real expert in this is, do you think that there are significant differences between the two IBAT inhibitors that we have in our hands right now?
So these two drugs are both largely non-absorbed. They are really working in the gut. And obviously what we're hoping to achieve is a blockade of the IBAT transporter in the terminal ileum. So to achieve that, we need to achieve the right concentration of whichever drug it is in that small bowel fluid to be inhibitory of the transporter. And I really think that the dose required will vary considerably from person to person, probably largely determined by what that small bowel fluid volume is, and therefore the concentration of drug that we achieve. And one of these drugs is now largely being used as a twice-a-day dosage, and one of them is largely being used as a once-a-day dosage. And again, the exact frequency of dosing hasn't been explored, never mind the actual dosing levels. So I think we do need to explore what the real doses are and try over time to find ways of individualizing that and see what the true requirements are. There's already anecdotes of people having swapped from one to the other and possibly gained benefit, but we're far from case proven. And I think there's suggestions in both directions. But intrinsically, they are the function of the drugs is very similar. But as I say, I think probably the biggest difference is going to be individual variability, and particularly the concentrations we're achieving in the terminal ileum and the consistency we can achieve those concentrations over the 24 hours or at least the periods where bile acids are being delivered to the terminal ileum, which is fairly extended periods. So traditional pharmacokinetics and things like that don't help us because we can't measure the concentrations in real life in patients in the terminal ileum. So I think, this is quite apart from the questions we've already addressed. I think future investigations and future data collection will have to try and tease out these important questions about whether changing the frequency of dosing, changing the quantity of dosing And it may even be that patients need more to get them under control, and they need different dose to maintain control as well.
And I think that message is that as of today, we cannot comment on appreciable known differences between maralixibat and odevixibat in our treatment decisions. But I definitely think it's a watch this space scenario. Um, let's think a little bit now about, we'll just go back to thinking about our patients from a practical standpoint. We've started them on drug. We've talked a little bit about patients who we might have caution. We don't have many absolute, or if any, absolute contraindications in Alagille syndrome. We have some patients who may have decompensated liver disease, but we may have exercise caution. We've thought about not that there not being known differences between the two drugs right now. Let's think about strategies for monitoring our patients once we've started them.
Yes, I mean, I think that the overwhelming is obviously safety. So we need to monitor them and make sure that they're not deteriorating, whether that's primary disease related or possibly as a consequence of treatment. Obviously, the criteria for stopping or interrupting drug in the clinical trials were very rigid, and quite understandably, there was great caution. I think we learned in the course of doing the clinical trials that actually there's huge variability of the transaminases in Alagille syndrome, probably much more than we appreciated, but it does cause some alarm, and we should watch it, because we can't ignore that, and it shows there's something happening in the liver, even if it is fluctuating and isn't always just going to carry on going up.
Richard, I think that's really helpful. Though I'm going to ask you one question: is since these are non-absorbed drugs, the transaminase issue, or even the bilirubin showing synthetic dysfunction worsening, as far as we know, this is not true DILI, right?
So that's a fantastic question, because obviously, yes, we don't think for one second this is a direct action of the drug on something in the liver. But of course, what we are doing is we are blocking the reabsorption of bile acids. Therefore, the enterocytes are exposed to very low concentrations of bile acids. Therefore, there's no inhibitory signaling going back to the liver. So we do expect that there will be some increase in bile acid synthesis. So in theoretical terms, it is possible that as a consequence of the mechanism which we're looking to achieve, which is interrupting the circulation, we may cause significant increase in bile acid synthesis in the liver, which may or may not be reflected by increased serum bile acids. In patients where we've looked at this in detail, it doesn't look like it's something that persists, and we see these fluctuations without persistence of elevation. But I think it's something that you can't ignore, and we just have to keep looking at that, monitor them more closely if they've got spikes, and then be prepared to stop if we really get worried if there's continued elevation. But that doesn't seem to be the case. I think serum bile acids don't tell us everything, but it does tell us something about whether there's been an improvement in the pruritus in a fairly, or at least of cholestasis in a slightly more objective fashion. Of course, it's the pruritus and the quality of life that's going to drive early requirement for transplantation or alternative therapies. But at the same time, it's good to have some objective measurement of whether we think we've done something. So I do recommend periodic measurements of serum bile acids, even if it's not what the patients come in complaining about. I do then, obviously, the question is, does it really persist in the clinical trials? There's very clear data, but it's only out for a year or so that the effect persists. Whether it persists all the way through puberty and growth and things like that, and the impact of hormone changes and into adult life, other questions we don't know. So we need to look out for safety, but we do need to look out for waning over time, because that is clearly a possibility. And then it comes into, then the next question is about other drugs as well, of course. And I think most of us are starting off patients on low dose of ursodeoxycholic acid and rifampicin, like in your patient, possibly antihistamines as well. And so virtually all the patients in the clinical trials were on those drugs when they went into the clinical trials. They were not on cholestyramine because of the overlapping action. So the really long-term patients have got a fantastic response. Then the questions have been asked, should we start withdrawing those other medications? And I mean, I think that I would certainly think about withdrawing the antihistamines, then rifampicin. Whether there's benefit to derive from withdrawing urso is a very big question. Actually, because I think this is really a cholangiopathy, I think maintaining urso long-term is probably a good idea. So obviously there's all the risks of chronic liver disease development, which we have to look at, whether they are becoming more jaundiced, whether they've got evidence of portal hypertension, etc., like in any other patient. And we can't pretend that that's just gone away because the pruritus has gone away. If the patient actually gets worse, is there benefit in pushing the dose up, or should we indeed be reducing the dose if the liver disease gets worse? And I don't know. I mean, obviously, in the clinical trials, there's undoubtedly patients that had drug withdrawn because they became more jaundiced, and they clearly, for safety reasons, it was withdrawn. But whether that was the right thing to do, I don't know. But clearly, if someone's got, worsening cholestasis, or certainly becoming more jaundiced, which is a marker of liver function, isn't it? Then we should be monitoring them more frequently, I think, as a consequence, because we do not know in those patients where we've got very little data on the deeply jaundiced patients. I think, obviously there will be patients that get the drug interrupted. I think if it's interruption for lack of efficacy, I think that's simpler. I think if the patient has had a benefit and we're stopping it for some other reason because of jaundice and things like that, then we should be really cautious about suddenly stopping drug, because that could potentially have worse problems as well. And the other thing which I touched on just briefly just then, which we haven't talked about in this, is the issues on cholestyramine, which was excluded in the clinical trials, as I say, for the overlap. But it is potentially useful if they do develop GI symptoms, of course, because we believe that the majority of the GI symptoms are caused by spillover of bile acids into the colon, and it's possible that at least in the short term, there is benefit from adding on cholestyramine to bind some of those bile acids and reduce the GI symptoms. And certainly in clinical practice, there's absolutely no reason not to do that, apart from the possible interference with fat-soluble vitamin absorption as well. So the spacing and timing is always an issue. But there's no intrinsic problem with using it in clinical practice, where there was in the clinical trial, of course.
I think that's a really useful hint. And it's certainly in an older child, you could offer them colecivilam, which could get away with some of the palatability issues.
Yeah. And if we really want to know, of course, by interfering with bile acid reuptake, we're putting these bile acids into the colon. So we are potentially causing effects there, and potentially causing dysbiosis as well, which is a whole new area which we need to look at in the future, and how we've changed the large bowel microbiota by using these drugs, and whether we need to address that by using probiotics and things like that. But these are all really important questions for the long-term health of these kids.
Absolutely. Couple more, I think, just interesting points that I think we should touch upon. And that's the question of, if a patient has a response to an IBAT inhibitor and then loses it, the effect wanes, or they don't respond, is there a role for surgical biliary diversion in Alagille syndrome? Now, my personal opinion is that I don't think, even in our pre-IBAT inhibitor era, that surgical biliary diversion worked that well for Alagille syndrome. It certainly doesn't have the same efficacy as we see in PFIC. And so my personal opinion would be that if a patient had a response to an IBAT inhibitor and then it waned, I would not be extremely favorable about offering a surgical biliary diversion, and would likely proceed to liver transplant. How do you feel about that?
I couldn't agree more. I mean, I've always found partial external biliary diversion a difficult sell to families. I had much better data, obviously, for PFIC than we had for Alagille syndrome. But even in PFIC, offering something with a 50% chance of success is not simple. I think if you failed to respond to optimized dosing of an IBAT inhibitor, so I think you need to push the dose up as high as you possibly can to make sure that you've really got what efficacy you can. If you've achieved that and you really haven't had a response, then clearly the chances of surgical diversion responding after that have to be a lot less than 50%. And I would find that very difficult to recommend to a family, unfortunately.
So then what about switching from one IBAT inhibitor to another? If we don't think surgical biliary diversion is a great option, how do we feel about switching from one to the other?
Well, there's certainly no data, and I've already talked about this a little bit, and I don't think we've got any head-to-head data. There's anecdotes of people having done this, and it may be that they've achieved better blockade with one drug rather than the other, and it may be to do with the distribution and the bioavailability in the small bowel. Logically, they are working in exactly the same way, but in individual patients, there may be benefit to be derived. Clearly, I think the chances of, realistically, if we failed on one, the chances of that have to be fairly small, and we really should be thinking about heading towards transplant if the quality of life is still terrible. Obviously, there's a few patients who are not candidates for transplantation because of their cardiac disease and things like that. And obviously, in those patients, I'm quite prepared to try anything to improve their quality of life.
I think that's right. There are no data to suggest that it's unsafe, and I would certainly rather try another IBAT inhibitor than offer surgical biliary diversion in Alagille syndrome. So I think, Richard, I think we've covered some really interesting topics. Well, I've really enjoyed talking with you today. I think that this is such an exciting era for pediatric hepatology. Certainly in the cholestasis world, we've just been handling off-label drugs, and now we've got data-driven new drugs in our hands. Clearly much still to learn, and you did allude to the ongoing efforts with the LEAP study in the US, and there's a LEAP EU coming where we're going to collect real live data of patients who were being treated in a clinical scenario rather than a trial scenario. So we do need more data, but I still think it's a moment to pause and to be really grateful to be in this era where we have this exciting new drug in our hands. So thanks again for this wonderful discussion, and thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.
This program was presented by Medscape Education Global.